Order, order. Welcome to the Health and Social Care Select Committee. This is the third session of our Community Mental Health Services inquiry. Today we will have three panels. The first are experts by experience, Christina and Christian Taylor. Thank you to them for being with us. And to those watching, we will be maybe hearing some very emotional and distressing testimony, but we are so grateful for them to be able to provide it and give context to what we will be hearing from next. Then in our second panel, we'll be hearing from local authorities, and in the third, we'll be hearing from the third sector. So without further ado, I'll pass to Danny Beals.
Thank you very much, Chair, and thanks so much, Christina and Christian. I'm hoping I get the right way around at all times, but if I don't, please do correct me. But it's lovely to be joined by both of you online. Thank you for joining us and for agreeing to share your personal experience today. I'm sure the team have already talked to you about this, but we really appreciate when people are sharing lived experience, that this is, it's their lives. It's not an academic exercise, and it can be emotional or difficult at times. So if you ever need to take a break or take a moment out, that's absolutely fine. And it's really, there's no wrong or right answers, it's your experience. So as much or as little as you want to share about any or all of my questions is very welcome. But it's great to be joined by you today. So first, I'm just going to ask some quite open questions, and starting with you, Christina. I wonder if you could take a few minutes just to tell us about your experience, and about your experience particularly of trying to access community mental health services.
Thank you, and thank you for inviting me today. It's a real privilege to be able to speak to you all. I was diagnosed with anorexia when I was 13. The treatment I received in child and adolescent mental health services was really good. It was ongoing between the ages of 13 and 18. The real challenges in my care sort of arose when I was discharged from child and adolescent mental health services into adult, which was zero, basically. Once I turned 18, I sort of wasn't anyone's problem. I went to university. I hadn't really got any coping strategies for being at university. So I had a pretty immediate relapse. I started drinking excessively, which I'd been doing on and off for a little while before that. And abusing laxatives. At university, I would take up to 90 laxatives a day. And I would make myself sick around 10, 15, possibly more times a day. I still had anorexia, atypical anorexia. My purging behaviours really increased. I was very fortunate in Leeds to receive really good care around the time that I was 21, a week after my final exams. I had been seeing a doctor and he insisted that I needed to go into inpatient treatment. I was very much of the idea that my BMI was not critical. I'd been told previously that when I got to a certain weight, it was a really bad thing, but because of the purging behaviours that I was exhibiting, he convinced me that I needed to go into an inpatient facility, which I was in for around 4 months. I don't believe that now, if I was at the weight that I was at, that I would have been admitted into services today. I believe the demand is so much significantly higher that my body weight was, my BMI was around 14, 15, something like that. So I think my BMI would need to have been lower because the services are under so much greater demand now. And I would need to be more critical. The whole time I was in inpatient treatment, I didn't feel that I needed to be there. I felt that I was bigger than other people and it wasn't really necessary. Obviously, retrospectively, being aware of the fact how unwell I was, I know that I did need to be there, but I felt that I could leave anytime I wanted. And actually, during that time, nurses did tell me that if I didn't eat, that they would kick me out, and the place would be given to a more deserving patient. I think the areas that I really want to talk about, the real failings in my care, came when I was discharged from inpatient treatment. Within about 3 months, I had a relapse, tried to take my own life, and they discharged me. I was eating, I was of a body weight that was fine, so I wasn't really getting much care around my eating disorder. It continued to worsen, and I moved back home to Norwich, where I live now. Moving back home to Norwich was the critical flaw, really. I went between health services. The services I'd had in Leeds were good. They'd kind of kept, West Yorkshire had really kept an eye on me. They weren't able to do much, but they made sure that I didn't really sort of drop off. When I came back to Norwich, I was very aware that another relapse was very quickly taking over. I went to my doctors. I wrote to Community Eating Disorder Services and said, I'm less than a year out of inpatient treatment. I really need some help. I received a letter from them saying, unfortunately, my BMI was 21, therefore I didn't meet their diagnosis criteria and they would be unable to help me. The result of that was that I lost a significant amount of weight and tried to take my own life again. I was only able to access paid care. My parents supported me with paid care. I was around 22 at this time. I could not have done that myself. I didn't have a job. My parents paid for me to go to therapy for around 18 months. I continued that therapy. I met my husband Christian, who's joining me today, and he attended. We found that I had to travel quite a long way for the therapy, about an hour each way. I had to pay every time I went. We were on very low wages at the time. We didn't have a car. My dad had to drive me to therapy. Nowhere in Norfolk could help me. I had to drive to Suffolk for help. The real problem that I want to talk about today in my care was during my pregnancy. I was told throughout my eating disorder I find it very difficult to get pregnant. So it was a huge surprise to me and my husband when I discovered I was pregnant when I was 26. I was on the pill. Probably because my eating disorder made the pill not absorb very well. I really never expected to be pregnant. I was thrilled to be pregnant and I wanted to have a healthy pregnancy. I told my midwife that I had a long history of eating disorders and I really needed support. I didn't know how to gain weight. I only knew how to lose it. And I wanted to have a healthy baby. My midwife didn't really know what to do with it because pregnant women don't get eating disorders. That's what they sort of felt. And she said, oh don't worry. And I actually was discharged by that midwife because we moved house. And so I continued to make myself sick throughout my pregnancy. And I really wanted help. I really wanted my baby. I was very, very worried about it. And I went to see my doctor and I said, please help me. Please refer me to a dietitian. I need help. I can't stop making myself sick. I'm so frightened that my baby's going to die, that I'm going to get ill. And my doctor looked me dead in the face and laughed at me and said, well, don't worry, if you don't eat enough, your baby will eat you. And I received no help. I was 16 weeks pregnant at this time. I received no help until at about 32, 33 weeks pregnant. I had a fall. My midwife lifted up my top to examine me and said, I can count your ribs. What on earth is wrong? Are you okay? And I said, well, no, I've been asking for help for weeks and weeks and weeks. Every appointment I've been to, I said, I need help. And no one's helped me. And I was immediately referred to Community Eating Disorder Services. I had a great therapist and they took care of me until my daughter was born. And my daughter was born healthy. She is now 13 and she is wonderful. And I'm so proud that she wasn't affected by my illness. I was affected by my illness. I weighed around about 6 stone 4 after I gave birth. I was very unwell. I went back to Community Eating. Sorry, this is very long. I apologise. I went back to Community Eating Disorder Services and was seen by them for the next year and a half until I was pregnant with my son. I expressed real concerns over the kind of failings in my care with my previous pregnancy and how unwell I was. I'd started to gain weight in a more healthy way, but I found that they weren't equipped to deal with my illness during pregnancy. Every time I got on the scales, I cried because I was gaining weight, which was my biggest fear. And eventually they said, well, I don't think we can really help you. Why don't you come back after you've had your baby? And so my treatment fell to the care of my midwife, who referred me to a specialist obstetrician who had an interest in women with eating disorders. And I don't believe that my son would have been born healthy or even at all if I hadn't received care from these two individuals. They went above and beyond their jobs. They saw me every 2 weeks and they were wonderful. And I really want to use this opportunity to say how incredibly valuable they were and how much I appreciated their care. Post-pregnancy, I was bounced around from services. I got stuck in between them. Every time I tried to access any kind of help, I was told, you've got an eating disorder, you need to be treated by eating disorder services. When it was postnatal depression, said, "You're too complicated, we can't deal with you." And so I spent around a year just trying to access help for anything. Whenever I went back to eating disorder services, they said that I wasn't ill enough to help me. And when I went to any kind of mental health services, they said that I had an eating disorder, so I couldn't help them. They couldn't help me. I was fortunate to be referred to Eating Matters, which is a charity in Norwich, and I had to pay for my care. But I found a therapist there who was really helpful, and I spent around a year with them. And it was transformative, and I was able to recover from my eating disorder at the age of 30. And I, again, would like to use this opportunity to recognise how important Eating Matters is, and the services have been, and how without them, and I had to pay for this service, but without them, I probably would still be very unwell at the age of 40. So I hope that's a bit of a summary. No, it's quite long, I apologise.
Hey, thank you so much, Christina. There's kind of so much there to unpack. You mentioned now that you've got support from the voluntary and community sector, and I think now you're also a volunteer for the national charity Beat. In terms of your work and the connections you've made with the voluntary sector, how much do you see the kind of experience you've had reflected in the experience of others that you've met or seen through those voluntary services? Is your experience quite common?
Yes, it's extremely common. As I alluded to in my previous statement, I think that it's much harder for people to access care, particularly in the last 10 years. I've seen a really dramatic increase in eating disorder cases when I'm speaking to organisations. I particularly speak to corporate organisations, but I also train medical students. I feel that because of the increased awareness around eating disorders, it's great that more people are recognising the symptoms and getting help. However, they're not getting help. They're coming forward. They're saying what's happening. I've heard horrendous stories. I have a very close friend who requested help a number of times, was told that he was a man, they didn't really know how to help him, and he now has a stoma and he's permanently disabled and unable to work in his late 20s due to failings in his eating disorder care. I've seen a significant number of almost everyone I've come across who has an eating disorder is also diagnosed with a neurodivergent condition. I have ADHD and was diagnosed later in life. Those links seem to be missed, and there's a large number of people self-medicating who have ADHD with an eating disorder, and particularly with autism and avoidant restrictive intake feeding disorder. There seems to be huge links with those that are perhaps being missed by neurodiversity pathways and care teams, and obviously these people are languishing on both eating disorder waiting lists and neurodiversity waiting lists. My son is currently on one that's around 6 years long, so I know the kind of waits people are facing. I've heard stories from carers of people waiting a year, 2 years for treatment when they're watching their children die in front of their eyes, being told that they are responsible for keeping their children alive. And I think one of the biggest concerns during my pregnancy was that I would have a relapse and I would be sent away to an inpatient facility away from my family and my young children. And so I overcompensated during my pregnancy to make sure that I wouldn't relapse when I had them. I think a huge part of my effective recovery was the support of my husband, and having him, being able to be with him, which I think Beat have mentioned in their reports, that how important it is to have a strong infrastructure and be around someone's family or loved ones. But I would particularly like to outline, and I'm sure my husband will also say, that setup for recovery is only really targeted around family when you're talking about parents. I think there is a failing when it comes to partners. I work with a young lady who lost her mother. She was a young carer from in her teens, and there was nobody like her. Her story's been featured in the awareness campaign this year. And I think for anyone who doesn't fit the mould of a young girl with an eating disorder, there's definitely some challenges around that. And even in the reporting of this, you always see young girls, force-fed young girls. It's not just young girls. A quarter of eating disorder patients are male. And I think that really does restrict people's access to care. If you're over 18, you're sort of not seen in the same way. Ethnicity, there are so many factors that restrict people's access to care. I certainly wouldn't have recovered if I didn't have the financial support of my parents. So anybody who didn't have access to additional support and funding, I don't know how they would recover the way that services are and have been in the time that I've been unwell.
Thank you so much. And you talked about interacting, Christina, with actually quite a lot of services at different points, your midwives, doctor, obstetrician, kind of lots of parts of the health system, but kind of still struggled to get heard and to get access and referrals to adequate services and support. Do you feel that kind of a common theme in your interactions was low understanding of what your experience was, the condition you had? Do you feel that anyone had adequate training or knowledge or awareness of the issues you faced?
I certainly don't think my doctor had adequate training, but I think that I think I've seen a kind of one of the bits of my role as an ambassador is training medical students. And one of the things that I've observed whilst training medical students is they are very frightened of eating disorders because they're very complex and there isn't really an easy solution to them. And I think that is reflected in a lot of health professionals. One treatment doesn't cure in the way that it does for a lot of other conditions. If you've got a broken leg, a cast will fix it. If you've got an eating disorder, one thing that you've tried with one person won't work on the next person. Eating disorders are, we lie a lot. I had to restore trust in my husband enormously throughout our marriage because I lied so much about my eating disorder. So I think it's very difficult for health professionals to trust that you're telling them the truth. And I think there's a lack of confidence with dealing with eating disorders because eating disorder patients are so deceptive and complex. I obviously have campaigned for GPs to receive more treatment, and I am so grateful, not more training, sorry. I am so grateful that they've done that, and I contributed to that campaign, particularly because of the failings in my care. Again, I think that if I was a 14-year-old girl, I think there would be, and I was anorexic, I think there's an easier pathway for people to follow because what the treatment I received in my teens in the 90s was perfect by the book. Everything was done really well. But as soon as I started to fall outside of the stereotypical category of someone with an eating disorder, people didn't really know what to do with me. And that confidence is, I think, what possibly contributed to their lack of understanding or support when I was trying to access support. And as well, things just weren't joined up. So the services weren't talking to each other. And then when I would say to one, I'm not getting treatment from another, they would look confused and act like they weren't aware of what was going on. And as a user, you think the NHS is one service, even though it's not. You need help. You don't know how to speak to all the different parts. You expect them to do that for you. And when you're asking for help, when I asked my doctor for help, it was the first time I'd asked for help in 13 years. And it was almost the last, to be honest, because of his reaction. I think I would really want this committee to know how difficult it is for someone with an eating disorder to say, I need help. Your self-confidence and your belief that you deserve help and you deserve to recover is so low. I just don't. Getting a negative response in that first request for help, it's co-critical. I think you lose people if you tell them they're not worthy of help.
Thank you so much. And Christian, just turning to you, kind of we've heard from Christina how central you were really to her support system. Could you talk a bit about your experience as the partner of someone kind of dealing with these issues, your kind of view of the journey that Christina's taken and how that's kind of reflected on your experience as a husband and supporter?
Yeah, of course. As you'd appreciate, I'm going to probably echo quite a lot of what Christina just said. So Christina and I have been together since her early 20s. So my experience of her accessing services started when she was pregnant with our daughter, our first child. So supporting Christina during this time, both during and after pregnancy, was a real challenge that in hindsight, as a 23-year-old at the time, I was kind of very much ill-equipped for. Seeing the partner that you love and care for, really struggled during an already stressful phase in life, was very difficult indeed. And that's why we were pretty desperate to receive mental health support at the time. Preparing for this and looking back, you know, it was quite some time ago. It was a while ago. I'm definitely not 23 anymore. I mostly recall Christina getting herself through it. Once she discovered she was pregnant, she kind of forced herself through a number of immediate lifestyle changes for the benefit of our first, then at the time, unborn child. She herself sought the support, chased up when it was lacking, like she attested to. Yeah, she was basically the strongest person I've ever seen during a time that must have been very terrifying for her. You know, pregnancy for someone suffering from an eating disorder isn't an ideal scenario. Yeah, she persevered through it all. You know, I'm very grateful that we've got two very healthy, lovely children now. But to go back to the point around her journey of accessing mental health services and support, she did, as she attested to, she did reach out for support directly to health services on a number of occasions during and after pregnancies. The experience from my perspective, and again, Christina's already kind of definitely sort of covered this, so we'll echo that. The overriding feeling was that during those periods, the health system either didn't have the local infrastructure to ensure that she was referred to the correct resource, or didn't have the support available to help a pregnant person with an eating disorder. So the first point regarding local infrastructure, again, like Christina said, she was passed between different NHS support areas due to being both pregnant or postnatal, because I said she sought support after pregnancies as well. And as well as suffering from an eating disorder. So a significant amount of time was spent waiting for referrals and then receiving letters stating that one area had assessed her criteria, but subsequently deferred her to another, like the examples that Christina gave earlier. So it was a bit passed from pillar to post, essentially. The second point that I made regarding the support itself, once support was confirmed and taking place, the level of quality varied greatly from practitioner to practitioner. From the GP that Christina's already mentioned, who was pretty flippant, there was a dietitian that was about 25 miles out. Again, like Christina said, we didn't have a car at the time to get to. That just kind of the dietitian listed off a series of foods that Christina could just try a little of and see. You know, and I felt, in fairness, some of this was probably caused by the first issue, that local infrastructure, in that the services didn't know where to place Christina, and therefore sometimes just felt that, you know, any support was better. It wasn't necessarily all a good fit. So yeah, I suppose, apologies, I've sort of rattled through that quite quickly, and I'm quite conscious that a lot of it is things that Christina's already covered. But I guess that those health services not knowing essentially where to place Christina so that she can get that required support, and whether knowing that support, which felt niche at the time, but in reality isn't, you know, whether it was available or not. It was a pretty scary time for the both of us, I'd say.
Did you, Christian? Because I think Christina mentioned how vital like family and you were to her, which, you know, I think kind of people exist within in kind of families and support networks, and they can be crucial to their kind of health physically and mentally. Did you feel as a partner, would you just kind of observing Christina through that process, did you feel kind of not able to influence, or were you included in those discussions, those, you know, when Christina did have appointments or access to some services for good or bad? Did you go along? Like, what was your kind of role in it, and how involved or not did you feel by the system?
I was there at almost all of them. I'd say, like, for support and for practical reasons, to be honest. At the time, I could borrow my mum's car. I was the only one that had a driver's license. And again, I guess going back to what I said, that varying sort of degree of involvement, and from practitioner to practitioner. Some of it I was essentially just in the room, and the focus was primarily on Christina. And maybe those examples, like the dietitian at the time, like the GP, was more because the support wasn't necessarily what Christina was requiring. Some others were a bit more, there was more involvement. Like, for example, there was, I can't think of a better way to articulate it, but it'd be homework essentially set, or, you know, challenges, or that Christina would be set to help her, to support her through, and therefore I would be involved in the sense that I would essentially make sure that we covered that challenge. So by the time we came back to the next appointment, we can actually say that we followed through. I think, but overall, and Christina, do interject if you feel that I'm misremembering, I think the focus was primarily between the practitioner and Christina. So yeah, I wasn't widely involved in all of the support services that were given.
Yes, thank you. And I guess because my time is coming to an end, unfortunately, because I could talk to you both for all day, because it's kind of incredibly valuable hearing your experience for the committee. But kind of reflecting on the report that we're going to write, which will recommend changes for the government and the NHS to make, I'd love it if you both could think of maybe one or two things in particular that you think should be included in our report that the NHS or government should change to I guess remedy the experience you've had and the experience that, as you said, Christina, many other people are having at the moment. So I'll come to each of you in turn. I don't know, whoever's ready first can go, and I'll come to the next person. One or two things that you'd like to see changed.
Okay.
Christina?
I would like to see a more comprehensive support offered to carers, and sort of rethinking of what it looks like to be a carer. My husband alluded to him, he was 23. The support he was offered, they said, oh, you can go to a carers group. Carers group was full of parents who were instructionally telling their children, they had a very different relationship to supporting the people in their care to a husband and wife. And my husband did not have anyone to talk to during my illness. He was watching me starve myself almost to death whilst pregnant with his child, and he did not have a single person to talk to, because he wanted to protect my privacy. He didn't want to discuss it with people close to us, so he did not have an outlet for that, and he carried that with him for years. And I think people who don't really looking at the fact that eating disorders don't have a type, don't have a particular look, and the people who support them are exactly in the same mold. They get missed in the people who aren't teenage girls. I think I would ask services to really look at the diversity of the people who are suffering from this illness and the people who care for them, and making sure that services are fit for purpose for supporting them. Because if my husband had had better support, he would have been in such a better place to help me. And I think both of us would have found a really frightening time a lot easier to navigate.
Thank you, Christina. Christian, kind of one or two things you would like to see us recommend change?
Yeah, absolutely. I guess piggybacking off of what Christina just said in terms of support for loved ones and partners, at the time when you're offering, when you're there as a husband, as a partner, to support someone who is in need of mental health help, you don't really think about support for yourself. Hence the reason I didn't bring it up myself at the time earlier on during this call. But yeah, that would certainly be something that I'd be keen to see included in the report. But also going back to my previous points, I guess the other thing would be changes regarding the referral routes and process. Ideally, Christina's experience when seeking mental health support during and after both pregnancies would have been much more efficient, and would have been, and therefore we would have secured local appropriate support a lot sooner. So yeah, that local infrastructure and processing, that would be one change I'd like to see.
Fantastic. Thank you so much, Christina. Thank you, Christian, for your time and for sharing your experience with us. It's been incredibly valuable. But back to the chair.
Thank you. So we're going to now bring our session offline just for a couple of minutes, and we'll be back. So those watching at home, don't go away. We'll be back as we change panels. Order. So welcome now to our second panel, which is local authority. So if we can start in our usual way, would you mind, for the sake of those watching at home, who you are and what you do, perhaps starting with Peter.
Thank you. I'm Peter Devlin. I am here on behalf of the Association for Directors of Adult Social Services. Thank you very much for the invitation. I have a substantive role with Essex County Council as a Director for Adult Social Care responsible for mental health. And I also still continue to work as an approved mental health professional a couple of times a month in Essex County Council.
Thank you very much. Councillor Lorraine Francis.
Thank you so much for inviting us back. My name is Lorraine Francis, and I am representing the great city of Bristol. I am the lead member for Adult Social Care, so I chair the Adult Social Care Committee that we run in Bristol. And like Peter, I qualified as a social worker many decades ago, and only recently stopped working as a social worker within an integrated team within one of the local authorities. So I come with a sort of range of experiences, not only as well as being a social worker qualified, still practicing. I also am here as a counsellor, so I feel that I have a kind of community perspective on this, and I also come with a person who is from a global majority background, so I come with that sort of also wealth of knowledge around being from a different culture to others, and understanding the journey that people experience. So I'm hoping we get the opportunity to sort of explore that. Thank you very much.
Well, thank you very much. So we'll start our questions with Ben Coleman, please.
Well, very good to have you both here this morning. Thank you so much for coming. I just want to look a little bit at the community mental health framework, if we can start with that, and the relationship, if you want, between that and local authorities and what they do. So you have the community mental health framework. It has lots of ambitions for integrated, that famous NHS word, person-centred care and everything. But how do you think local authorities can best make that happen, support the process of making that happen? I don't know if I could start maybe with Peter and then come to Lorraine.
Okay, well, thank you. I mean, I think that local authorities have a substantial and long-standing role. I think that the extent to which local authorities are involved across the country does vary at the moment. But I would probably start from an association point of view of saying that we see mental health and our responsibilities to mental health and mental well-being as being a societal consideration before a health consideration. And I would take you to population health analytics that kind of clearly indicate that a substantial 80% of good years of life and length of life is related to wider social determinants. So it's related to...
We're going to come back to that in much more detail later. Yeah. Absolutely.
So 20% being related to specialist health. Now, I appreciate that that's a generalisation. And I think we have to hold on to the fact that there are individuals that are more substantially affected on a longer term basis by their mental health needs, and therefore we need to understand the inequalities and the issues that they experience and ensure that there's provision for them. But for a large amount of individuals, we over-rely on a medicalisation, a pathologisation of illness.
Which is particularly perhaps why I was talking about local authorities' role. So if you wanted to focus on that, that would be interesting.
So local authorities have a civic responsibility first and foremost. So when we talk about social determinants of health, most of those social determinants of health are relating to local authority duties in one way or another. Yeah. When we talk about prevention and public health initiatives, again, local authorities are the lead in that space. When we move on to the commissioning of non-NHS community care, local authorities tend to have established and trusted relationships with community voluntary care sector and faith enterprises. So they are in the fabric of our communities. I think the mental health transformation, because in particular the funding flows and the targets that have been set have been very diagnostic specific. So I think we've had a focus on understanding people as patients and symptoms rather than understanding people as people with needs and focusing more on the need rather than the kind of the need to silo diagnostic pathways in the first instance.
Okay, that's very helpful. I mean, Lorraine, is that something you'd agree with?
Yes, and I think one of the things that the community mental health framework was supposed to do is reduce the barriers between the physical and mental health. Yeah, so that it was about integration, working together, prevention, to sort of ensure that we are person-centred. So we want to be able to be person-centred. Person-centred in real life, in real terms, means huge resources, huge amount of staffing and a huge amount of time, because person-centred mean that you are working with you on your journey, just like our recent speaker in her specific area. She needed at least 6 teams around her in order for her needs to be met. So that's person-centred. But without the resources to back that up, we are running up the hill backwards, and that's one of the real challenges that we have. So in Bristol, what we have is one of our teams, the MINT team. We are working in partnership with the ICB, for example, and we have social workers, part of those teams, working around service users to try to ensure that their needs are met from a social perspective and from a health perspective, because that's the whole process of working together with the ICB. We're trying to problem solve earlier to prevent that revolving door of services, but that's incredibly hard when we're talking about mental health, because mental health is not an entity that you can just do a tick box and resolve it. It's ongoing. It's always changing. And
absolutely. I mean, but you're trying to bring everybody together, and I appreciate the desire not to take this, well, certainly Peter, this diagnostic approach, but we do nonetheless need to work with the NHS closely on this. What difference is the 50% cut in funding for ICBs going to make, do you think, to what you're trying to do? But I don't know, both of you, if I wouldn't.
Okay.
Like that.
If that is what's now going to happen, that we are going to have a pooling of our budgets, which is 50-50. At the moment, it's not that in Bristol, as you know, we've given evidence here before. It's 70-30 or thereabouts. So if we were to have a more pooled budget where we are having a split, we will be actually saving a lot more money from our social care budget, which will then help us to do more preventative work. So that's the aim of having our Section 117 funding issue, as you know, is in crisis at the moment, because we are funding it much more than the ICB are. And I'm wondering if the challenges with the changes that's coming up is going to affect that as well, with the new changes that's going to come into place.
Maybe that's what I was wondering. Maybe, Peter, you have a view on that as well.
Well, I mean, I think the obvious areas are a retrench on prevention and community provision, actually, and the resource being focused on those with critical needs. So I think we could, you know, the position that we're in could be entirely against the NHS 10-year plan if we're not careful. So my you know, that's, I think, a big consideration for us. And this obviously comes at a time where we've got the mental health bill that's going through legislative reform as well. And we're hoping to see more people outside of hospital and community provision. So the cuts directly to the NHS could mean that kind of what we would consider as the preventative side of things, the softer interventions earlier on, could be scaled back further. I think we already see the challenges in public funds between local authorities play out in relation to Section 117 responsibilities. I'm sure the committee's heard that, and the lack of clarity around that in CHC. So the more the financial constraints hit public services, the greater there is a risk that we have cross-boundary disputes over finances, which get in the way of the provision of good quality integrated care.
I mean, do you feel when it comes to dealing with on the ICS, ICB, do you feel that you're equal partners with the NHS, or do you feel that they run the show and they let you in a little bit? I mean, I suppose across the country, I'd be asking for Bristol's particular experience, which sounds different, and Peter, across the country, what do you think the general feeling would be?
I think there's a big kind of cultural bit in the local systems that relates to the ICB and relationships. So I mean, I would certainly say in North Essex we have a very good relationship with our ICB. It does feel like there's a genuine willingness to partner. Culturally, I think the environment is a healthy one. Overall, I think that the majority of funding in mental health comes through the NHS lines. And I think as a consequence of that, local authorities have struggled to really lean into that and to be equal partners in relation to decision making, both in terms of setting strategy, involving communities and the delivery of that. in a way that is a shared investment. Most local authorities across the country, for example, have not seen a benefit in relation to funding flows into local authorities as a consequence of the community mental health transformation and the SDF funds that came into the system. So 30% of our local authorities across the country have seen a financial flow into their services, which has enabled them to commission greater community provision. Most of it has gone into specialist clinical interventions. And that goes back to my initial point that clinical interventions are absolutely required for some individuals with complex needs, and there is no doubt about that. But there is also a lot of support that can be provided by our community sector, our community mental health teams that you hear from later, from families and what have you, with the right societal infrastructure in place, but it does have an investment requirement.
Yeah. Thank you, Lorraine.
Yeah, I mean, I think the relationship with the ICB from local authority perspective in Bristol has been relatively good. It has not been a situation where there is conflict with regards to the ICB. The conflict had been around funding and not having a clear government strategy or guidance around spend. So that is what creates the tension between the ICB and local authorities. So I think with the greatest of respect, I don't think my role is to sort of knock what the ICB has tried to achieve. It's more to do with the funding, and their hands were tied just as much as ours, and we ended up, as in social care, having to deal with the deficits, because you cannot not let people have access to care, so you therefore have to fund it. So the fact that it's social care that's predominantly funding it is it was one of the outcomes of that, but the relationship itself has been positive.
Thank you.
Thank you very much. So if we can pick up on that theme, actually, let's talk about funding and joint commissioning. So obviously under Section 75 of the 2006 Act, this is possible, but doesn't always happen. What's your experience of joint commissioning, and where is the best practice in the country on this that we can look at? Lorraine?
I mean, we have some examples, like I was alluding to, in regards to the Mint team, where we joint fund with the ICB to ensure that we have practitioners across.
How easy was that to do?
It was something that needed to be done. I'm not on the ground with delivering that, but from what my colleagues tell me, that was something that was incredibly important to achieve. We have a men's house as well in Bristol, which only caters for 10 men. However, there is something about, when we talk about, because I guess this is where our knowledge will come into, when we talk about complex cases, we are not just talking about with the incredibly profound testimony we just had from one service user around eating disorders. We are talking about psychosis, we're talking about psychotic illnesses, non-psychotic illnesses, and within all of that streams, you have varying levels of degrees of complexity. We also have the added issues around what is it that's driving some of these issues, and we're talking about housing inequalities, we're talking about race inequalities, we're also talking about, which is quite important that the previous person spoke about, the actual growth of the amount of young people, unfortunately, who are experiencing challenges with their mental health and well-being, and how in about 5 years' time, our 15-year-olds or our 14-year-olds are going to be in adult services if we do not weave in preventative services within that. Because without having a real... Some of you won't be old enough to remember, 20 years ago or so, we used to have counsellors in school. That was then pulled out, and now we're in a situation where we have we have critical levels of young people going online.
We know that the government does have a plan to reintroduce some of this, although we have questions about the money allocated in order to achieve it, right?
Absolutely. So it's all about how do we do that without
Peter.
funding.
Yeah, so I'll go back to my first statement. Mental health is a societal issue. Yeah. So I'd like to see these Section 75s extend further. I think pulling...
There's a consultation, of course.
Yeah, and there is a consultation at the moment, which we are feeding into.
Yeah.
I would like to see housing, education be part of the opportunities for Section 75 pulling, because I think we need to make sure that there is accountability and ownership across the public sector as a whole. And I think that mental health is well established, that the fabric of our societies have a direct relationship on our population's mental health. So unless we tackle some of those more systemic issues in the first place, then we won't move the dial on that. I think we also need to move away from trying to distinguish people by different categories and cohorts. Now, and that's not to that is not to detract at all from the need for specialist interventions where that's required. But there are so many people that we see that have multiple diagnoses that are excluded from services. There's an inverse of care system almost. The more complex you are, the less likely you are to receive the right kind of care and treatment. And I think that needs to flip. I think it needs to be about need, because there is so much that can be provided if we look through the lens of need, first of all, understanding the person in their context, in their social systems, in their communities. And the individuals that are most affected and disadvantaged in terms of inequality, which results in premature death, premature ageing, disability, are those that are marginalised and excluded by society in all of those domains. So until we start to think about reasonable adjustments in the education system in all aspects as being something which is responsible and incumbent upon all ministerial portfolios, we run the risk of continuing to compound inequality.
Would you agree that actually probably the best place to do this is at local level, right? Rather than local government level, not decrees by central government. So is there an opportunity in the devolution agenda, do you think?
I think there is definitely. I think there does need to be a paradigm shift, though. I think that mental health is the system and the structure. I think is the system is the platform is burning for mental health. It's a very strong set of words you've just said there. The platform is burning for mental health. What do you mean by that? I suppose what I see in the acute care is an increase year on year of mental health act assessments that are having to take place. So people are entering into a state of crisis before interventions are forthcoming. I see the focus politically sometimes on the acute hospital care and old age and frailty. And I see in Essex, and I think this is common across the country, more and more people having to go out of area to receive hospital care, completely dislocated from their families. And when going back to the social determinants of health, we know that that's not good for them in terms of their medicine. So actually, I do think that this is a point in time where we now need to shift the paradigm towards need. We need to bring it back to local government. We need to think about how we reform the funding structures. So that there is more of a balance on prevention. We need to protect prevention. And we need to look at non-clinical interventions as having parity and as being as important as those clinical interventions side by side.
I'd also add to that we know our data in Bristol tells us that there are fewer people training to be AMPs, for example. If you look at the situation in Bristol, the majority of AMPs are older and they're leaving the service due to burnout. So when we talk about community and what community looks like under the community mental health framework, we're talking about staffing and we're talking about people professionals being able to deliver the work and in an increasingly...
What needs to change to turn that around?
Well, what needs to change, I think, is that we have a situation where you have them and us. So you have the practitioners, and then you have the service, the people using the service. And it's always pitted against each other. And there isn't a kind of coming together of, I need help and this is the team that can help me. It's very, very separate. So when a practitioner, day in, day out, is being labelled as being incompetent and not being able to deliver, when in fact, during that COVID period, I think within the team I sat in, we saw 30 staff come and go. Staff were literally walking through the door and walking out the door between 21 and 23 because the work was too intense for the people coming into services, and it was the older people, the older practitioners that were able to cope with it. So we need to see more people training, more support. This is the basic stuff about having more staff in teams, smaller caseload in order to be able to deliver that person-centred approach. Because if you are stretched having 30 plus cases and you are trying to deliver service within a complex network, you are going to get staff burnout. So if we don't address that aspect of it, we will continue to see staff leaving the service and not being replaced. So when we talk about community, what exactly do we mean by that? We are getting more cases of service users with neurodiversity issues coming in, you know, people with respect learning difficulties using services, working age adults using services because they have to. And also we cannot not mention the online issues around people going online to get advice and then having to come back into services when it all goes terribly wrong. And I know that there's work being done around that.
Can you give us some examples of what you mean by that?
Okay, so right, so let me just make sure I'm going to give you nameless experiences. Yep. So when we have had service users come in and they go online to diagnose themselves, then they come back into services and say, but I've read that this is what needs to happen. And then you end up in conflict with those very people that you're trying to support, because online groups say, no, this is what you should be doing, this is how you should tackle your health issues. And unless there is some kind of restraints and some kind of ability to shut down those sites sometimes, we would always say you need to refer to the NHS website if you're going to be getting advice, because the advice you're getting is not going to be helpful.
And you've seen an increase in this kind of presentation
recently? Absolutely. I stopped working within adult mental health services in September 2024. Yeah. I've now gone into a different setting where I'm working with younger people. I'm trying to be anonymous. Different setting, because I work part-time in another setting providing therapy. So I'm seeing a different
so this is an emerging trend that we should be looking at.
Absolutely. Okay. Online is creating major problems for practitioners trying to deliver a service.
Okay, that's very helpful. So, I mean, let's move to the wider social determinants now properly. So, you know, can you perhaps describe for us, in the experience of your work, starting with Peter, the relationship between local authorities and the NHS and the third sector? How does that all interplay in your experience?
So I think the local authority tends to have a commissioning relationship, an established relationship with its community sector partners. Certainly that's been my experience. So local authority tends to be the lead commissioner for any non-NHS services. That's changed a little bit with some of the community mental health transformation, where we've got on occasions ICBs and sometimes NHS provider trusts, commissioning through to community partners.
That relationship is potentially going to change. I mean, Jim Mackey said that he wants ICBs to be much more about commissioning and far less about providing those services. So do you think that's going to be a shift from how it is currently, or have you got any opinions about that?
I would welcome the shift, but I mean, I think the funding.
You prefer if the ICB was commissioning?
I think the local authority is best placed to commission, because I think we need to ground this in need, and I think my concern would be that what we don't want is an NHS commissioning framework then trying to be deposited on a community sector where actually there needs to be a different feel. It's not just about activity and performance outputs. So we need to recognise that the ICBs generally have a relationship with big NHS providers, and they commission in quite a contractual way. There is a lot of infrastructure and there's a lot of contractual reporting around that. Local authorities tend to commission with VCSE sectors, which are smaller, their infrastructure is smaller and what have you, and they're often more locally based. So I think, you know, if we went through existing relationships that are already established and trusted, for me that makes sense. Yeah. Local authorities understand their populations, and they are well placed to provide that. The health and wellbeing boards are well situated as a convener to local systems and could be elevated and given.
What do you mean by elevated? And I ask this slightly pointedly. I mean, when I hear people talk about health and wellbeing boards, they generally enjoy sitting on them. They have a great day out where everyone sort of pats each other on the back. But then in terms of what they actually are able to achieve and do, and, you know, what did I achieve that day? There's a sense that actually we talked a lot, but maybe not more than that. So when you say they need to be enhanced how exactly?
So I think the convening stuff, and I think, you know, I think you've touched on the ceremonial aspect sometimes, the relational aspect and the kind of convivialness of bringing partners together. And I think there is a relational component in all of this, culturally as well. But I think I would say that health and wellbeing boards need to have more accountability. I think that there should be more accountability within them. And I think my experience is that sometimes they do have that accountability, that collective accountability, and sometimes it does feel that it's...
Also, they don't have the teeth.
Yeah, and so I would be saying that we need to go further with the accountability that they have.
Oh, that's what you mean by accountability. Yeah. So accountability for them to have the teeth to be able to hold
for them to have
others to account.
Absolutely, and possibly to use them as the vehicle for protected funding for particular areas. The Public Accounts Committee last year or the year before made it very clear that whilst we talk about parity esteem for mental health, that there isn't a parity of finance. No. The distribution of finance across the health economy is disproportionately weighted to physical and medical conditions against mental health. So actually, I do think that the Mental Health Investment Standard, the Better Care Fund I touched on already, isn't spending on mental health generally when we look at that nationally. And actually, the Health and Wellbeing Board could be the vehicle for discharging local funds, which in itself is probably likely to give it more authority and sway in local systems.
What about what about the police? So what kind of relationship does the police have with all of these organisations, because they're often the last point of call for a lot of people in crisis?
Well, I mean, the police have got a very interesting role when it comes to mental health, because often if you are in the community and there is somebody that's unwell, most people will call the police to help. Somebody's walking in the road, somebody's putting their life in danger, they're putting somebody else's life in danger, and it's often the police who will be called out. They used to, I think, I'm not sure if they still do, have the ability to 136 people and to keep them safe whilst services look as to whether somebody needs a Mental Health Act assessment or not. And I think that the police were becoming overwhelmed with that and were stepping back from that direct role of being responsible and accountable. So I think that they have a role where they need to be dealing with crime. Having a mental health isn't a crime. So therefore I think that kind of reliance on the police to manage challenging behaviours in our communities is unfair for the police and definitely unfair for the service user, because to have a mental health doesn't mean that you're committing a crime. You're unwell and you need support in that moment. So that would be my answer to that really, really interesting question.
I mean, my truth on this would be that the police probably over the last 2 decades have been drawn into more mental health related work. And I think that does correspond with a reduction in investment and a corresponding increase in demand of mental health issues. I think there will always be a need for a police response where there is an immediate public safety and threat that can't be contained safely and together with a mental health response. But I think the police, through the right care, right person, I think the principles of that, doing the right thing by individuals, ensuring the safety of a set of circumstances you encounter, whilst providing that in a way that is least restrictive and most personalised. Those principles, I think, are very sound and solid. I think the police are right to rebalance the work that they do, but that does mean to say that the health and social care system needs to step into the potential gaps and voids that creates. So I think it needs to be done well at a local level, collaboratively, where there is a set of principles that guide that, and there is a process by which systems and its constituted parts can properly evaluate to make sure that there isn't gaps being left. Otherwise, I think we end up in a system and a situation whereby the individuals themselves could be left without the right care.
Have you got a view, and I'll ask both of you this question, maybe you can weave in your comment into that, Councillor Lorraine, about what the perfect system does look like? Is it the Health and Wellbeing Board sets objectives with teeth to hold others to account, with pooled budgets that means that there isn't fighting over scraps and targets that align? I mean, what is your view, given your vast experience, the both of you, of what a good system could look like?
I would say that firstly, can I just go back one slight step in regards to the police and why in Bristol their involvement in mental health was becoming increasingly problematic? It's because we know that when your skin is brown and you've had decades of being overrepresented in the criminal justice system, adding another layer when the police are intervening around mental health is adding another layer to that and is increasing the data. So that's really important perspective as well. But in regards to your question around what's ideal, it's interesting because we've been having conversations about the Health and Wellbeing Board. So I sit on the Health and Wellbeing Board, and if the chair is not around, I will chair, but I have no role other than that. But I am part of that. And one of the things that's been coming up politically about the role of health and wellbeing, they're going to hate me for saying this, in Bristol, is whether they should come under the banner of be more integrated into adult social care. It sits under adult social care, but as a kind of concept, yes, we sit around, we talk, and we have different partners coming in and talking about their area. So if we talk about very briefly, if we talk about the dentistry issue, for example, the Health and Wellbeing Board, you would think is the place to find a definitive response to that, and they will default to, well, that's the NHS. You know, we have no role in fixing that problem. Yep. So it does bring into question how much power they have as a Health and Wellbeing Board and what else could be done. Yep. So what needs to be done is that we do need to have health and social care as being the headline for decades, but yet we have a split service, and health and social care are not integrated, not working together as a holistic whole. So when people go from the community into a hospital and come back out again, we need to be working holistically, and we do have case studies around that, but we don't, you know, I can send you that.
He's writing to us with
yes,
that.
we can give you that. So we do have examples of where that is working in regards to housing. However, we know that we need more staff, we need more funding, we need young people training, because social work numbers are dropping as well. I don't know about other parts of the country, but we are seeing a dip in people stepping up into social work as well. So we're losing the very essence of social work is social workers and social care. We need professionals. We cannot default to a system where we don't have trained practitioners that have a really entrenched understanding of services. We need to be working in partnership with our voluntary organisations, because we have devolved all of our...
Are there barriers to that we should be live to?
In regards to voluntary sector?
Yes.
Yeah, so one of the things
They're up next, so I'll ask them the same thing.
Yeah, I mean, within Bristol, there are specific voluntary groups that we go to, and it's not all perfect. Is there enough? That's a question. We have a fantastic organisation called Milari that has been working for quite a long time with people from the global majority, and they are entrenched in our communities. And we also have other named services, but I do not know, and it will be interesting to hear from our partners shortly, whether we need more localised services, because I don't know if we will have the expertise, because that takes time to build your reputation. It tends to start really small and they tend to evolve. So do we need more voluntary sector organisations, because we're spending millions of pounds on commission services, you know, for domiciliary care and all, you know, the other care services, but we don't invest in no way, shape or form in community resources, and we don't invest enough in preventative services.
Your ideal system?
That's a great question.
I don't think I answered it.
No, I think you did.
Or just elements of it. Principles are fine.
So I would go to population health management stuff. The things that tell us about actually what people need to live well first. And I would look at the extent to which they are in the fabric of our societies and infrastructure. So I think there does need to be proportionate universalism. I think we need to invest in areas that you know, and this links to the council's levelling up agenda, the government's levelling up agenda, and local councils levelling up agendas. So I think there is something about getting the fabric and the conditions for people to thrive and remain well and be well and recover right. I think there needs to be a much more targeted sort of second layer prevention focus, which is led by public health and recognises the kind of population demographic and individuals who could tip into unwellness and what they might need in relation to something which is more purposeful and targeted. I think there needs to be an integrated approach which really does recognise and balance the importance of the way that social care and the whole personalisation, thinking about individual strengths, seeing them as individuals and systems.
We
and
have a sister inquiry that
is absolutely looking at that. I think there needs to be much more of and I think with that, there needs to be sufficiency planning. So there needs to be around, what is your population need for those individuals that are likely to require social care services relating to their mental health.
Why isn't that already happening? I thought that was the whole point of the Health and Wellbeing Boards, was to come up with a strategy that took into account all of this, and then ICBs were meant to help to deliver that, or at least have regard to that strategy. Why is that not happening? Because in theory it should be happening, isn't it?
I think in theory, it should be happening.
Yeah, but why isn't it in your experience? That's a very instructive.
Well, I think there's a couple of things. I mean, I think I would go to. We need to make sure the funding flows into the system, and the system is the guardian of what its population requires, rather than the NHS.
Would you like to see the Health and Wellbeing Board managing the overall budget?
I would like to see the Health and Wellbeing Board having a much more solid and robust role in relation to managing the finances of health and care, making strategic decisions against priorities. I would like to see. I think we've called in ADAS for a sufficiency plan to support with an impact assessment to report the reforms in the bill, because we know that unless there is the right community infrastructure, both in terms of its volume and type, and integrated with health, that actually we won't shift the dial on people moving into specialist mental health services and into hospital services unless the infrastructure in the community is right. So I think that does need to be addressed. And I think this needs to be underpinned, whether we use existing infrastructure and bits of legislation. So we spoke about the Section 75 and the opportunity to open that out as a facilitative means of being able to support local systems to pool funds. We have got the Better Care Fund. Should we have a ring-fence component to be spent on mental health? Should the mental health investment standard go into social care, mental health as well, to make sure that we've got a balanced range of provision? So we could use some of the existing infrastructure that we have in funding flows, but to pivot them if that was what government was minded to do.
Thank you. And very briefly, if I might, Lorraine, you mentioned your Bristol City Council's innovations recently, particularly around housing. Could you give us just a sense of what that is and where are we with this project currently? And that's my last question before I move on.
Okay, so we've got an integrated housing care offer. So it's where we have a situation where housing and care works together. We're funded partly by the ICB as well. So when you're in hospital, we're trying to look at how we can provide housing. It's kind of like we've got two great sort of things going on. We have our housing strategy, which is whereby we're looking at people living in the community. Their health is paid for, but their housing is paid for by benefits, by the normal housing benefit, which means that we can have a situation where you're not having to provide the whole package of care for somebody living locally or living in the community. And that is proving to be excellent. So we have two major projects going on at the moment where we are, we're working with our voluntary sector housing to provide specialist housing in communities, and we are working, the health element is paid for, but the housing side of it is paid for by by benefits, which is an excellent way of looking at care in a localised way. Yeah. Because without that, what was happening is we are funding 100% care for people living in the community, and we just don't need to be doing that. So it's a great way of saving money, and that's really important. And we can send in more evidence to you, because I won't be able to give you the perfect answer, and I want you to have the perfect answer, so we will ensure that you get that.
We're extremely grateful. Please do that.
And in regards to the Health and Wellbeing Board, that is a really important, really big issue that I'm going to bring back as well, about how best it could work for the betterment, for the greater the greater city, so that it's much more effective in what it's trying to do. And I think that's a really good point.
Lovely. Thank you so much, both of you. Really appreciate your time with us this morning. Without turning off the cameras, we're now going to get our third panel up. Thank you so much.
Thank you.
Thank you very much. So if people at home are wondering, the two microphones at the end are broken, which is why we've got everyone on one side. But it also means that from certain angles we can't see all the nameplates. So what we're going to do, if I may, as we did with the last panel, please would you introduce yourselves and what you do? Can we start with Penny East, please?
Hi, my name's Penny East. Thank you so much for the invite to be here today. I work for a charity called Think Ahead. We were set up around 10 years ago to better embed a social approach to mental health provision throughout the NHS and local authorities. And we do that by recruiting, training and developing mental health social workers specifically. And through that we've trained around 1,200 and we've built up a real expertise around the challenges more broadly around the mental health workforce.
Lovely. Thank you very much.
My name's Stephen Parker. I'm the National Head of Service for Mental Health in an organisation called Turning Point. And Turning Point's a large national VCSE organisation that works in mental health, it works in learning disability, autism, substance misuse and sexual health as well. But I'm a nurse by background, psychiatric nurse. I've been qualified for a very, very long time. And I spent about 25 years in the NHS, so I kind of think my experience goes between both statutory and non-statutory sectors.
Thank you very much.
Good morning. My name is Duncan Tree. I'm Director of Strategy and Relationships with the Association of Mental Health Providers, and the association is the national membership body for 300 plus voluntary and community sector mental health providers in England and Wales. 8 million people in England and Wales access some sort of mental health support from the voluntary and community sector. 2 million of those people via NHS-funded VCSE delivered services. The services that the sector provides include inpatient, residential, community-based care coordination, and some of the specialist services that your previous witness, Christina, talked about earlier on today in relation to, for example, eating disorders. Many of our members will also provide related care and support in relation to people with learning disabilities, autism, who also have maybe homeless and have drug and alcohol substance misuse needs.
Thank you very much.
Thanks for inviting us.
Dr. Becky Cooper, please.
Thank you, Chair. Thanks so much for being here. So we heard in our previous panel about the relationship between local authorities and integrated care boards. So I'd like to start the questioning by asking for your thoughts around your relationship, the voluntary community and social enterprise relationship with commissioners and providers. Is it a genuinely good relationship? Is it an equal relationship? Are you equal partners? And if there is room for improvement, what areas, what policy levers do you think would enable that improvement? So perhaps if we could go along the panel, starting with yourself, Duncan.
So it's not an equal relationship. It can't be an equal relationship because I think it's premised on, in the first instance, the commissioning or the procurement of services. I think the extent to which it's a good relationship varies in parts. So, for example, in some parts of the country, we've seen the community mental health transformation agenda or narrative translated some, I think, probably more meaningful, authentic relationships between VCSE organisations, local authorities and the NHS.
If I can ask you, what facilitates that? Why is it varied?
Well, so the example I'll give you is probably in Durham, where the leadership arrangements or the facilitation of the voluntary and community sector's engagement in community mental health transformation has been led by the local authority. and it's the local authority that's invested in the VCSE alliance there. I think there will be other examples in other parts of the country, for example, North East Somerset, and the work that's been led by our colleagues in Rethink, that will exemplify the extent to which some colleagues in the NHS have facilitated meaningful and authentic engagement of VCSE organisations. But in many instances, I think the default will be to those larger providers, and many of our smaller members, particularly those working in specialised services, may have felt excluded for some of those alliances and indeed the discussions that have led to them.
Okay, thank you. So I'm picking up there's definitely a strong relational element there.
I think there's a relational element, and it points to a wider issue about there's an acute and ongoing focus on the system and the structural requirements in relation to improvement of services. And I think your previous witnesses today have alluded to some of the behavioural and the cultural considerations that are critical. And those are embedded, I think, in the power relationships that we've talked about. So a stronger focus on cultural and behavioural. And indeed, earlier on, I think the committee chair referred to the extent to which there should be perhaps a greater devolution of responsibility for delivery. I think we'd like to see some clearer focus on some national outcomes and some national expectations in terms of the nature of the integrity of those relationships and the extent to which local systems are held to account, both in terms of the investment in the VCSE sector and the authenticity of the agreements that deliver those.
Thank you. Stephen, any further thoughts?
Yeah, I mean, Turning Point operates across the country, so we have lots of different relationships with lots of different ICBs. My experience has been one of non-equality, but we have to put it in the context sometimes of the size of contracts that VCSE organisations work in a specific area. So you've got an ICB, and we might have £1 million worth of business in that place, and obviously the NHS have got 100 million or whatever. So there's something about proportionality that I think is really important. And there's also something about just the sheer amount of VCSE organisations in any one area, and then you think nationally as well. So it's very difficult to get a single voice because we all have slightly different ways of thinking about things. So I completely agree with Duncan's kind of posit that there needs to be some sort of national outcome tool or measurement that kind of brings people together so we can not measure ourselves against each other, but kind of together see what works. And without that, I don't think we'll ever be in a position where we can be at the top table in the ICBs. I think we're too small and individual. Duncan's organisation does some great work in bringing us together, but you only represent a small amount of the plethora of different organisations out there.
Okay, thank you. And Penny, any further thoughts on that one?
We're a national organisation. Our partnership working is directly with NHS trusts and local authorities rather than ICBs. I would say in terms of that partnership working, we have some brilliant partnerships, but the one big challenge is about that multi-year partnerships. Unfortunately, because as a charity, our funding is uncertain, and we're working with partners whose funding is also uncertain. So long-term partnership is always going to be very, very hard when you're working in that context. And I would say that's got increasingly challenging in the last year to 18 months, where NHS trusts that we've had long-term partnerships with are unable to partner with us, citing financial reasons. And that is definitely something that has become more pronounced in the last 12 to 18 months. And so that kind of multi-year partnership working where you really get to know each other, you really get to know what the local population needs, and you can adapt your work to make sure that the partnership is most effective. That just isn't possible when operating with such funding uncertainty.
Yeah, that's really helpful, and we might come back to that later, I think. So if I can just move on, and perhaps, Penny, I'll stay with yourself around the Department of Health and Social Care and NHS England in terms of how they are facilitating that relationship and helping you. And you've talked about national structures and national targets. In their written evidence to ourselves, they have stated that there has been a substantial increase in the involvement of VCSE organisations as partners in the delivery of holistic care for people with serious mental health problems. So they think that things are improving in general. So Penny, I wonder what more you think they could do to ensure perhaps that VCSE organisations and providers can feed into national policy and be a further part of that conversation, and whether you think it is fair to reflect that things are improving generally. So
as a charity, we're funded by the Department of Health, and I think in terms of reflections about how we could be better utilised, we've been going for about 10 years. And in that time, we've built up a huge database of 100,000 people across the country who want to work in mental health. We've got a ton of metrics and data about what drives someone to want to work in mental health and what indeed might make them leave the sector as well. And I think where one of the frustrations is that we're not necessarily utilising that data in a partnership agreement with the department or with NHS England, and sometimes it can feel a bit transactional as a contractor who's delivering something and meeting their KPIs and doing the best that they can. But actually what we'd really like is a more collaborative partnership working where we can look at all the evidence that we've built up over the last decade, which is so fundamental to building a really happy, healthy mental health workforce, and share that with the department and share that with NHS England in order to drive policy change, particularly around the long-standing workforce challenges around recruitment and retention.
That sounds very sensible, Penny. So perhaps, Duncan, if I can come to yourself, and perhaps if we can expand this conversation slightly, because I'm aware that AMHP, you've delivered or you've developed a map of VCSE services. And I wonder if you could perhaps tell us how that's being utilised currently, and perhaps at a national level and a local level, and whether you think that sort of can be better utilised to sort of provide improved services through commissioners and providers and that wider national structure.
Yeah, so you're right. So we've undertaken two pieces of work over the last 2 years. One which involves the mapping of VCSE and other statutory services in relation to mental health and mental health social care and support across England and Wales. And we've also in the last 6 or 7 months produced a mental health social care workforce mapping tool that provides some more granular detail on the nature and extent of the mental health social care workforce and the vacancy rates as currently exist and the need for investment across that workforce, which includes the need for firm and clear investment in relation to social work, occupational therapy, and the wider care and support workforce in relation to mental health. We use the term mental health social care and mental health social care workforce to make that distinct from a clinical NHS workforce, and we think it's a term that's got increasing traction. We're working in partnership with colleagues at the LSE and Manchester University through some NIHR funded work, an incubator project that's looking to further exemplify the value and the investment requirements of the workforce. So we've been encouraged by NHS England's interest in the work that we've done, and indeed that from colleagues at the Department of Health and Social Care. And I think the 10-year health plan provides us with an opportunity to utilise that more effectively at a local level, particularly in the context of the rollout of the 24/7 neighbourhood mental health centres and the aspirations for neighbourhood health and care programmes which DHSC are leading on. And I think which we understand that they are really, really clear that social care and the VCSE will be clear and equal partners in those rollouts, because the success of both programmes are contingent upon that meaningful engagement.
So they're really interesting terms to use. Thank you, Duncan. I think they're very clear, which is great. So the mapping, just to clarify, it is being used currently in sort of national structures, or you're hoping that it will be used further?
So we've got an indication from colleagues currently at NHSC or NHS colleagues that will be returning to DHSC that they see its value, and we hope to be using it with them. And I think on the back of those conversations, we'll expect some colleagues at an ICB and local level to be utilising those more effectively. I think, if I may, it relates to a point that I don't know if the committee has heard today, is that at the end of 2021, NHS England required all local systems to produce mental health integrated mental health workforce development strategies and plans. And that expectation was clear that they should be produced and delivered in conjunction with local authorities and the voluntary and community sector. We're not aware of having seen of any of those, and I think it would be good to see what was produced at the time, and indeed what, if any, intentions there are to reproduce those in relation to the commitments in the NHS 10-year plan.
That's really helpful, thank you. I'm sure that we will all pick that up. Thank you very much. So if I can just move on perhaps with yourself, Stephen, around meeting wider social needs now. So we heard from the previous panel around local authorities, and there was a clear direction from the previous panel around the social determinants of health, particularly mental health outcomes. And we are, of course, aware that VCSE organisations are already working around the social determinants of mental health, and there is some great examples of best practice. What more do you think can be done? I'm sure there is more that can be done to ensure that local authorities and the NHS are supporting you to more effectively integrate with community mental health services? And if you want to talk about those wider determinants and how you think you can better work there, that would be really helpful. So, Stephen, if perhaps we start with yourself.
I mean, I think where it works well, it works really, really well. I've got some really good examples of, for example, a crisis house we've got in the north of England that is just opened its doors to going into A&E services to take people out of A&E so they don't need to sit in there, and that's in conjunction with both the NHS and with local authority kind of agreement. So there are some really good pieces of work that go on, and I see the VCSE work as kind of like the glue that holds the statutory powers and the work that NHS and local authorities do, which are really important work. VCSE kind of hold the glue to that. They're the ones who are actually working with the service users on the ground quite often. They're the ones who have the relationships. They know them best. If you think about a supported accommodation, for example, people are with people 24 hours a day, and so they know them really, really well. And I think the way to help do that more is to allow VCSE people to continue to do that. We were just talking before about short-term contracts and about the nature of 3, 5-year contracts. We are seeing that change a little bit, and we're just looking at some much longer ones, which is really useful, because then we can start to think about how we can help people in the longer term, because I think it's really important for us to recognise that, and Pete Devlin was talking about it a little bit before, that whilst recovery is so important for lots of people, there's a significant cohort of the people we're talking about today who recovery isn't an option in the truest sense of the word. And when you've got short-term contracts, when you've got recovery as a goal, it kind of all leads to that kind of short-termism and not being able to actually get to the bottom of what you're talking about. So in that crisis service, we have a fantastic service user who works with us a lot, actually. And she's quite a high-flying person, but she's got a severe mental health problem, and she needs to come to our crisis service every now and again for maybe 3 days, and then she can go out and she can do her fantastic work again. And I worry if it would be very easy to cut the funding to something like that, because it doesn't fit in the criteria of what statutorily people are supposed to have to deliver. It we're subcontracted. So what happens to that poor woman if and when the crisis house disappears? We've suddenly got someone who will be allowed to escalate her behaviour and probably get picked up by the police and probably get sectioned and probably put in a mental health unit and eventually ruin her life for a significant period of time. So for a very small amount of money and long-term relationships, you manage to get people having happy, healthy lives. I mean, would
have thought that return on investment and prevention is
so
effective. Amazing. Thank you so much. I'm aware of time, so I'm going to pass back to the chair. I'm sure there'll be further questions around that. Thank you.
Thank you very much. Greg Stafford.
Thank you very much. So I think the committee has heard about the bureaucratic barriers that organisations like yours face, it's particularly smaller ones, is when they're accessing funding. So what do you think the solutions or policy levers might be to address those barriers? Maybe Stephen start with.
I mean, there are some really simple, really complicated, but obvious things that we can do. And for me, there's something about the length of contracts and the parity of esteem that we might have with VCSE and statutory organisations, where, I've had examples where that A&E pilot that I was talking about before was pulled after a year to sort of save the A&E £80,000, and they've since 2 years later reintegrated it. And we can't work like that. We're hiring people and firing people, and and we've managed to get funding now for 2 years, I think, but it's not something that is sustainable in that way. So there needs to be an understanding, and having worked both sides of the fence, there is a sense of looking down on VCSE people as the gophers who run about, and we do all the important work and they just look after people when we're not there, and I think that culture needs to shift.
Thank you. Penny.
I think in terms of us as a charity working more efficiently and effectively, it would be incredibly helpful to have national workforce plans that work across both local authority and voluntary sector and the NHS. There are a number of different workforce plans for those different areas, but actually what matters to somebody in need of support is workforce crossing all those three sectors. And I think for us as a charity, we spend a lot of time navigating different sectors in different parts of the country, which all have different frameworks and different targets. And that, as a national charity, is a real challenge. And while, of course, we absolutely understand the need for those local agendas and priorities to be understood, that national policy can work across both NHS and local authority. I mean, for us as a charity, we train social workers, and there's a real lack of understanding that social workers actually work directly in the NHS. They're not in the NHS workforce plan. They're directly employed by the NHS working in clinical teams. They're not just in local authority settings. And so kind of lack of understanding there on a national level makes our lives much harder in the sense that we sometimes feel like we're running through treacle. And so, yes, a clearer kind of workforce plan that crosses NHS, local authorities and the voluntary sector and understands that social work will work across all three.
And how does that potentially have an impact on how you access funding, would you say? Or if it does, or does it not?
Well, I think we are funded directly by central government, and we're a single funder organisation, so in that way it's possibly a lot simpler than other charities. But I would say I've worked in the charity sector my whole life, and at Think Ahead and in previous jobs as well. I think until you work in the voluntary sector, you can't have any idea of how much time is taken up by trying to work out where your money is going to come from. And it's not just the uncertainty, it's also the fact that funders love to change frameworks and targets and ways of doing things. So you think you've got it down, and then next year they've changed it, and you have to change the way that you work. And the amount of capacity and energy and kind of skill internally put to those challenges rather than doing the work that you actually came in to do. And so it's kind of working with funders to be far more supportive and to not change if it's not broken. Like, don't change things for the sake of it, because it really has an impact on our ability to do the work.
Thank you. And Duncan, I think your organisation has argued for multi-year, and Stephen was touching on this, multi-year funding. Sort of what would that model look like, and how would that fit?
Well, I think I think Stephen's alluded to it, really. It'd be premised on actually a better understanding that actually the recovery narrative doesn't work for everyone. So much funding and much procurement and commissioning, and actually much commissioning isn't commissioning, it's actually procurement, because commissioning would start with an identification of needs on a whole population basis. Some of us are young enough to remember joint strategic needs assessments. We need to be thinking about this in the context of the conversation. And I think that probably loops back to your point about actually what's required in terms of investment in the sector, and that is understanding that the sector is more than a provider of specialist services, a meaningful strategic engagement that understands that the sector has a lens on an understanding and an ability to articulate and respond to needs that statutory services don't have in many instances. So I think the COVID experience was a very, very sharp and acute and uncomfortable experience for many that exemplified the extent to which voluntary and community sector organisations increasingly occupied a safeguarding space that was vacated by the state, by statutory services. And the default, there has been no reset in many circumstances. You talked about prevalence and complexity earlier on. I think what many of our members see is a change in the nature of acuity of need being presented to services and to the services that they provide. Now, some of that may be a function of the bar being raised in terms of access to NHS services, but it may also be a function of a change in nature of needs that we need to understand, I think, in a clinical level, and more research is required. And Steve and I have talked a lot about this with our colleagues. So it's acuity as distinct from complexity and prevalence, and we're not entirely convinced that the national system has got a lens on that yet or is sufficiently equipped to interrogate it. So I think engagement needs to be strategic. It needs to be based on more than just a procurement relationship and more than just an assumption that the third sector just provides meaningful activities that can keep people occupied between clinical services.
I mean, I think you've explained the sort of the ethos, the sort of circumstance there. Are there sort of practical or systematic changes that would need to come about to get to the kind of funding model that you're hopeful for, or is it simply cultural?
I think it's cultural. It's, as Stephen's alluded to, it's a or been explicit about it. It's a changing understanding of the value of the sector, not looking down on it, but actually some clearer national standards and targets and expectations have to be required of local systems if we are to, or if the VCSE sector as both a provider and a strategic enabler and partner, if that engagement is to be more than something just invited to the occasional health and wellbeing board meeting, which, let's face it, don't have much teeth in relation to oversight and delivery of mental health services, because the architecture sits largely and has oversight from the NHS, and that's where the funding flows. And I think if we were to ask a question about resources, we should be asking whether or not it is right there's a substantive amount of resources for mental health services flow through the NHS, or whether or not we should be thinking about different funding routes.
Thank you very much.
Interesting. Thank you very much. Josh Fenton-Glynn, please.
Thank you. I'm going to go a little bit rogue and not ask all the questions I've got written down here, because there's a bit of an elephant in the room, which is that very recently the government white paper on benefit reforms has just come out, and a significant part of that is the people who are on various forms of PIP because of mental health reasoning, and we have a significant mental health backlog in the health service. And I just want to quickly go across the panel, really, because I think you've got kind of the frontline experience to ask. Firstly, what has the impact of some of those announcements been, but also what more work do you think we can do to really drill down and kind of reduce those lists in terms of using your frontline experience to kind of reduce the mental health waiting lists and support people in the way that you were kind of outlining with some of your cases there? I'll start with Penny.
So I think from our perspective, as a kind of recruiter and trainer of mental health social work, in terms of mental health waiting lists in particular, we find that with people on those waiting lists, they often feel like they aren't having any support while they wait. And the psychological impact of that is that you can't feel better, you can't get better until you get the intervention that someone's told you that you need. But actually, from a social work perspective, they will have a lot of social needs while they're on those waiting lists for that therapeutic or clinical intervention. So how can we support social workers to be working with people much earlier? It's not about kind of... your previous speaker was talking about an over-medicalised approach where both practitioner and service user is waiting for this clinical response. And a clinical response, of course, is necessary for a lot of people, but it needs to be in combination with a social work response as well, who understands the social approach, can look at things like poverty, housing, domestic abuse, their education and employment opportunities, to give them that holistic care. In terms of the announcements around supporting people back into work, employment as a health outcome, we're hugely supportive of, but it needs to be done in a safe and voluntary and appropriate way. And as well as supporting the person themselves in order to find work, it's also about working with the employer as well. Employers need support in how to make sure that they're making reasonable adjustments to make their place of work a safe and suitable place for somebody with long-term mental health needs.
Just to get on that, I mean, obviously, as a social worker, would that be something that you'd support people into, or social workers would support people into work, or kind of work with their employers? Would that be part of the remit?
So a social worker would definitely help with a lot of the attributes in terms of something like building confidence. It's very based on relationship-based practice, really individualised support, so making sure that the barriers to someone feeling able to find work definitely could be navigated. So things like confidence, help with transport, that kind of thing. There are also specialist support networks as well, like IPS practitioners, and they are specifically there to support people to get into employment, and they also work with the employer, crucially, to make sure that the place of employment is suitable.
I'm just going to quickly move to Stephen. Your reflections on the impact it's had on people who are waiting, kind of mental health support, and that you are supporting, and then also a bit about the kind of how it could practically drill down on those lists.
Sure. I agree with most things that you said, but we work across a whole wide range, a gamut of different mental health conditions, and we're talking about severe mental illness today, and It's too early to tell with those people in supported accommodation and hospital accommodation what the impacts will have. Obviously, people haven't been reassessed for their PIP or whatever yet, and I'm cautiously hopeful that those people will continue. It'll be recognised those people are able to live fruitful lives, but maybe not be contributing financially to society. And I think we need to accept that sometimes. I'm most concerned about the people who are on long waiting lists, like you're talking about for talking therapies and psychological therapy, who are who have major depression or anxiety, or stress that can't work. And I understand that those are the people who are likely to be most affected. I'm a massive advocate of employment, the employment advisors. Our problem, like all of our services, is they come in and out of fashion, and they get funded and that gets taken away, and you've got a year's funding for this and 18 months for that, and then the new thing comes in with a new set of metrics, and I think we need to land on something and say, well, let's try that for a little while. Because it's very difficult to, again, build relationships with people with mental health problems and have them trust you to get them into that, and work with the employers if you're changing personnel the whole time.
Duncan.
Yeah, thanks. So it's a really important question. So with our colleagues at Association of Directors of Adult Social Services, Child Poverty Action Group, BASWA, Association of Directors of Public Health and the Centre for Mental Health, we, about 3 years ago, published an open letter calling for a review of the efficacy of the social security benefit system in relation to its alignment or otherwise with the objectives of our health and care system. I think that call and the rationale for that call remains. I think it's exemplified by the recent announcements in relation to PIP. We know that the NHS Confederation's work about 4 or 5 years ago identified that people's concerns with the PIP process were significant features in terms of their mental distress in terms of people in inpatient arrangements and their discharge and any related discharge and support. I think, if I may, I think the Casey, or the Commission being led by Baroness Casey, is an excellent opportunity to review that. We understand that the Department of Health is commissioning some work in relation to the utility of attendance allowance or its current arrangement in relation to support for older people. But I think more generally the review of Casey gives us an opportunity to understand the importance of mental health social care and the care and support system in relation to supporting people with poor mental health or living with mental illness and their unpaid carers, I think, in the community. And we hope that opportunity isn't missed. And I think, if I may just quickly, the point I made that Christian made in relation to unpaid carers earlier on today's evidence is absolutely critical. Too often services commissioning approaches the needs of unpaid carers through a lens of homogenous needs, and the needs of unpaid carers with family members in the mental health system are quite often distinct, and not least because the system can feel very adversarial for them.
Thank you, and with apologies to the Chair for going a bit rogue there. I'm going to get back to the broader questions on the role of social workers in enabling community-based mental health. You've argued, Penny, that a lot of opportunities are missed because we don't have the right mental health social workers in place. Could you just tell us a little bit about those opportunities that are missed?
Yes, certainly. So as I say, we work with NHS partners. There are roughly around 3,500 to 4,000 mental health social workers working directly in the NHS. So not in adjacent services, but actually working with those clinical teams. It's proven that they have a real impact of widening clinical perspectives, to just be there to look at someone's whole person, to look at someone's social circumstances. They look at things that possibly other practitioners might not necessarily have the training or the capacity or the time. So an example would be that one of our lived experience partners was telling me that when she was in hospital, the clinicians would often come in and talk to her over the bed. So she would be lying in bed as they were talking over her about her medication. It was a mental health social worker who intervened and said, why don't we all just sit in chairs in a circle so we can be eye to eye rather than looming over somebody. So it's social workers who look at the power dynamics between the service user and the clinician and are able to help the person navigate a system when the system can feel traumatizing, the system can feel really challenging, and a social worker is there placed to navigate it. In terms of what we could be doing, increasing the number of mental health social workers, 3,500 to 4,000 in the NHS is obviously a very small number. At Think Ahead, we are turning down hundreds of people every year who could be mental health social workers, but we don't have the funding to train them. They want to work in mental health, but they don't have medical backgrounds. Mental health social work is a really effective route for them to get into those teams, but it's a really small number, 3,500 to 4,000. So in terms of social work being the answer, over the 10 years, we would love to see a workforce plan that prioritised social work directly in NHS and increase the number of people that become mental health social workers.
I think that's brilliant, and that answers my next question, which was about what needs to be done to enable. So you'd like to see it through the NHS long-term workforce plan. Yeah. I'm now going to just move on to Stephen. My background is as a cabinet member for social care. In Calderdale, we did a lot of work in trying to integrate health and social care and actually get integrated teams. In 2020, we produced a report looking at the deaths of 5 substance abusers who had broader mental health problems, and one of the things that we found that were key to that was kind of integrated services and wrapping services around people. Now, I also know that that's very key to the work that Turning Point do. So just kind of a broad question is, what work have you done trying to integrate services and bring in integrated services around these use cases?
Thank you so much for asking me that question. It's my passion, if you like. I spent an awful lot of time as a dual diagnosis worker back in the day when it first came out, and I've been close to comorbid substance misuse and mental health ever since, and been quite sad and upset when I go back to my nurse consultant colleagues and they're still fighting the good fight in the NHS and still fighting against the same things as we were in 2002, 2003, 2004. So we had this big wave of dual diagnosis, the next big thing, and integration is really important, and concurrent services don't work. You need to have some level of, all the research was done back in 2005 and it hasn't been disproven yet. However, obviously with changes of government and austerity and all the rest of it, all those things went away and people retreated back into their holes, if you like. I mean, in Turning Point, we are very fortunate that we work in both mental health and substance use. And we have got some models of really good practice, which unfortunately aren't replicated around the country. It's very much a local commissioning decision to do this. Obviously, substance use is commissioned through public health, and mental health is either through health or through the local authority. And so it feels like there are lots of different types of funding streams. But it's very simple that you train up substance use workers to be able to look out for symptoms of mental health. We know that something like 72% of people in substance misuse services have a significant mental health problem, and we know that about 40% of people with a mental health problem have problematic substance misuse. So when you've got services who say, well, we can't help you because you've got an alcohol problem, you need to sort your alcohol problem out before I can give you therapy, and then they go to the substance misuse team, and the substance misuse team say, well, you really need to get on antidepressants before we can, how can you possibly give up alcohol? Then it's all going to fall apart and people fall through the gaps, and I know that I'm probably speaking to people who understand that. However, I think the points are really important. It's very simple. You just get all the people in the same either virtual or actual space. There's a lot of evidence to suggest that actual space helps. And like the 24/7 hubs are thinking about, you bring substance misuse into that, and then you can have a one-stop shop, if you like, for all your needs around physical health, around mental health, around social health.
I think one of my biggest victories when I was running those kind of services was getting the mental health trust to actually look at people when they were and help them when they had substance misuse problems. Because actually, I mean, I don't know if this is your experience, but we found that a lot of people were just self-medicating with the harder drugs. Yeah. And so, you know, you ain't going to fix one if you're not doing both. And it's almost strange to me that we talk about multidisciplinary teams whenever we're in a healthcare setting, and then when we're talking about social and healthcare, it just gets dropped off. And I just wonder if you could reflect on that.
I mean, I worked at a time when most substance misuse services were also done by the NHS, so I managed mental health and substance misuse teams, and even getting those cultures together within one organisation was almost impossible. For me, there's something about coming alongside the person. I think the wider determinants of health question is really important. If you haven't got a house, if you haven't got stable relationships with people, and you're on heroin and you've got schizophrenia that you're not taking your medicine for, I believe that getting your relationships and your house sorted first is going to help with both of those things, because people are self-medicating. But if you go to health, they're not dealing with housing, and if you go to social care, they're not dealing with relationships. So that's where the VCSE come in, I guess. And I think that triumvirate of support together in one place, looking at Maslow's hierarchy of the needs of those who are old enough to understand that, where housing and shelter and safety are like number one, kind of, you need food, water, house and safety in order to do anything else. If we go back to that very basic tenet, I think we'll have much more success than cherry picking what we do, which is what we do at the moment.
I think the role of voluntary sector has to be not to fill the gaps, but to provide the glue that sticks it all together.
Absolutely, that's my belief.
You've got that perfectly. Sorry, I'll hand back to the chair.
No, that's lovely. Thank you very much. We've got 1.5 quick questions left. So I just want to turn to the digital. So obviously it's a shift that is in front of a Secretary of State, prioritised that as his top baby of his 3 babies. But we've heard today how important your sector is in holding all of this, being the glue in the mental health space, and that applies to other sectors in health as well. I wonder what more needs to be done. Now, Penny, you started talking about this. So you've got data that you want to share, that you'd like to share. I'd love Stephen and Duncan's perspective on that as well. But also if we could talk about digital infrastructure, because it's not just about having the data, it's also about interoperability and being able to easily flow from one stakeholder to another. So perhaps, Penny, would you like to elaborate a little bit on your remarks, and then we'll go to everyone else on that topic.
Certainly. From a data perspective, as a national organisation, we have gathered a lot of data around how to recruit people and how to retain people. That's on a national perspective, but we've managed to map it onto local population needs as well, to be able to see what conversion rates, if you like, you need to be able to, when we're trying to recruit people, it's the recruitment tactics that you might need in Cumbria are different to, say, in London. And we can see that from a data perspective. We've got those metrics, and we're very eager to share it with central government and indeed commissioners.
Have you tried? Have you offered it?
Yes.
And what did you say?
Well, we just don't necessarily have those types of conversations. We do absolutely offer those insights, but most of our conversations with our funder are more about the contract that we're set up to deliver. The metrics and the data that we've learned over time is because we're trying to create the best programme possible and the most effective programme possible. We're not necessarily being measured on it by our funders, so therefore it's not always at the top of the list. Mm-hmm. In terms of digital infrastructure, I think so we hear a lot about AI improving efficiency. Certainly in social work, there's a lot of evidence of it improving efficiency within a service. I think where there's more potential is how it works cross services as well. It's not just about improving efficiency in your bit, it's about how AI can be used across the whole sector. But I think before even getting into that, it's really important to get the basics right. So when we have surveyed our social workers, we found that around 10% of social workers don't have a decent Wi-Fi connection in their office. And we found 60 to 70% of them don't have devices that work, that can use the latest piece of software or system that they need to do in order to put up their case notes. So while digital transformation and AI is hugely exciting, without the actual basics infrastructure, do they have devices that work? Do they have a decent Wi-Fi connection? And crucially, do they have the training needed in order to use the new systems? Yeah. Quite often you put the money into building something that looks fancy with no development costs and no training, and people don't know how to use it, and then it doesn't work, and then we pay for another system. So I would absolutely say that while there's loads of exciting developments in this area, getting the basics right has to be there as well.
Thank you. Stephen.
So I think shared systems are really, really important for if we're going to start looking at evidence for if these things work. Because if we're talking about lifetime journeys of service users who maybe start off in CAMS and then end up in a care home in their later life, how are we ever going to know what works and what doesn't work? We have real issues with getting data about keeping people out of A&E, for example, because when we discharge someone from our crisis house and they go off into their lives, we have absolutely no way of knowing. We don't have any right to the data, and I understand that, but some way of being able to access a shared pool of information, or being able to feed into a shared pool of information, I think would be really important. The other thing I just wanted to mention is the rise in digital solutions for therapy. And I think that's it's a very exciting time, and AI, I read some research last week that says that in one particular study, AI was as good as a human therapist. And I wonder, after 30 years' experience of doing this, whether relationships are really important, and I don't want to lose sight of the relational aspect. We use, within our talking therapy services, we use Silver Cloud and various other sort of systems, and the outcomes are good for those people, but it wouldn't work for everyone. And I really worry that because it's cost effective and it's easily auditable and everything else, that we'll sleepwalk into everyone can have this kind of AI friend. It won't work for everyone, and loneliness is one of the biggest causes of mental ill health in the population, and if we further keep people in their houses, it's only going to get worse.
Thank you very much. Duncan?
Yeah, so I think there are probably two aspects to the question, but if I can just follow on quickly from Stephen's point about the absolutely fundamental importance of relational care that's premised on continuity and coordination, and I think that was very, very clear to us when we heard from your first witness this morning, the point about coordinated continuity and a relational dimension to that care, as opposed to transactional. And I think the procurement relationship, the requirement for commissioning, has introduced too much of a transactional relationship into care, and where there is an endpoint at any given time. And I think we need to sort of challenge those assumptions and stick to the principles of personalised care and support. We need to hear much more talk about the principles of personalised care and support and co-production with people that use services and their unpaid carers in relation to mental health care services. We hear a lot in relation to, for example, services for older people, but less in relation to services for people living with mental illness and experiencing mental distress across the life course. And I think that's a dichotomy we need to address here. A number of witnesses I think today have alluded to the differentiation between children's and adults services, and I think it's a real challenge in terms of continuity, keeping people safe and wider aspirations. The digital stuff in relation to, if I may say stuff, in relation to data, NHSE have committed and have done some interesting work with us over the last few months in relation to some improving, I guess, the expectations of VCSE organisations in terms of the data that they're required to return on the back of NHS contracts, and the extent to which the data set is as helpful as it might be.
So you think they're waking up to the fact that you do have this data, and actually it might be helpful if they collected it? So
data is required by the NHS of those organisations that are delivering certain specified contract services. Some have found that onerous in terms of their capacity to deliver, obviously, and so the expectations in terms of reporting need to be proportionate and reasonable. There's the issue also in relation to the extent of the quality and intelligence of the data that VCSE organisations and sector holds on local needs that's of value in terms of the commissioning of services, and that perhaps isn't as well interrogated as it might be, but delivering that, of course, comes at a cost to those organisations, because it's not cost neutral. The issue about digital access to services, and there are, of course, digital exclusion issues that we need to factor in relation to poverty, and those in relation to the provision of therapy, digital therapy, are slightly different, and I think they need to be unpacked. The conversation about digital mental health services is multifaceted. It is more than just actually a means of delivery. It's also, as Stephen's talked about, the extent to which services can be provided via digital therapy.
Thank you very much. So the half question is, obviously we are writing this report as we go, and I'm going to ask you for one and one only recommendation that you think we should be making to government. Penny, what would yours be?
Can I make a quick clarifying point just about what you asked about the data? I fear I gave an unclear answer. When government came in last summer and talked about expanding the mental health workforce, we did write to the Minister and offer our data and our metrics, and that wasn't shared. So I felt I was giving an unclear answer. We have absolutely directly
but they
offered
didn't take you
to
up.
meet to talk about the expansion of the mental health workforce and our insights that we could share around that, certainly, but they didn't take it up.
Okay.
In terms of one thing, it will not surprise anyone to hear, it will be increase the number of mental health social workers, both within local authorities, but also crucially within NHS trusts as well.
Very helpful. Steve.
Local services with people who know what they're doing with a national infrastructure.
Thank you. Duncan.
A requirement for all local systems, NHS and local authorities, to engage with the VCSE mental health sector as a strategic partner, as well as a provider of services.
Lovely. Thank you very much. That brings us to the end of today's session.